Happy New Year. So today we are going to be discussing about the etiology as well as diagnosis of mitral stenosis in the pediatric age group. So as probably most of you know that the name mitral is derived from the word mitre, which is nothing but a bishop's hat. So if you look at a bishop's hat, if the mitral valve is placed upside down, it would resemble a bishop's hat, and that's how it derives its name. So a mitral valve is basically a complex composed of four components that include the mitral valve annulus, the anterior and the posterior leaflets, the sets of chordae tendineae, and two sets of papillary muscles, that is the anterolateral and the posteromedial. So it is always good to describe the mitral valve, especially if it is abnormal, in terms of these four components. So whether the annulus is hypoplastic or normal, whether the leaflets are abnormal, thickened, whether the chordae tendineae are normal, short, absent, and whether the papillary muscles are normal, absent, or small. Coming to the annulus, so annulus, if you ask the surgeons, they would probably describe or define it as the level of visible transition between the left atrial myocardium and the whitish leaflets. And histologically, it is defined as the fibrous hinge line of the valve leaflets. It is not a single plane structure, rather it is saddle or D-shaped. The mitral annulus, it's also not a static structure, it's a dynamic structure, and it tends to become short during ventricular systole. It's very difficult to define the limits of the mitral annulus, especially because of the continuity with the aorta anteriorly. Coming to the leaflets, so mainly two leaflets, anterior as well as posterior. So leaflets, they are composed of a collagenous peripheral fibrosa and a medial portion which is myxomatous tissue, also called as spongiosa. As we all know, the mitral leaflets do not have any attachment to the septum, and that's one of the ways by which you can differentiate a mitral valve from the tricuspid valve. The anterior mitral leaflet, it is a sail-like structure, and it is attached to the anterior 1/3 of, or rather anteromedial 1/3 of the mitral annulus. And if you look at the posterior mitral leaflet, it is much longer at its base, or rather wider at its base. It covers the 2/3 of the posterolateral part of the mitral annulus. However, when you look at the length of the posterior mitral leaflet from the base to the tip of the leaflet, it is short compared to the anterior mitral leaflet. The cross-sectional area of both the leaflets is around 20% more than your aortic, the mitral annulus, and which allows them to overlap during ventricular systole. In the closed position, the commissure, which is formed between these two leaflets, looks like a smile, and the two ends of the smile are described as the commissure. So really there should be ideally only one commissure because there are only two leaflets, but because it's crescentic shape, the two ends of the commissures are labeled as anterolateral and posteromedial commissures. In addition, the leaflets are divided into three scallops. So from lateral to medial, they are A1 and P1, A2 and P2, and A3 and P3. Coming to the chordae tendineae, they are collagenous structure embryologically derived from the valvar mesenchyme. In general, there are three types of chordae tendineae which have been described. So you have the marginal chordae tendineae which attach from the papillary muscle to the free edge of the mitral leaflets. Then you have the rough zone chordae tendineae which are attached obviously to the rough zone of the leaflets. And then you have the strut type of chordae tendineae which are attached to the base of the posterior mitral leaflet. The chordae tendineae, as I mentioned earlier, they are remnant of the valve mesenchyme and attached to the papillary muscle. They help in distributing the force radially along the valve leaflets. each leaflet is connected via this chordae tendinae to both the papillary muscles. And then eventually the papillary muscles, these are a group of these are actually closely spaced muscle groups which are situated in two regions of the trabecular LV myocardium, that is the anterolateral and the posterior medial portion of the left ventricle. The blood supply also differs for these two sets of papillary muscles. The anterolateral papillary muscle has dual supply from the left main as well as from the left circumflex coronary artery, whereas the posteromedial papillary muscle has a single source of blood supply from the right coronary artery. As a result, the posteromedial papillary muscle is more prone for ischemic insults. A little bit about the embryology of the mitral valve. So, the mitral valve develops from the fusion of the endocardial cushions, which starts happening after the 4th week of gestational age. So, once the superior and the inferior endocardial cushions have fused, it results in two orifices, the right and the left AV valve orifices. The posterior mitral leaflet arises predominantly from the lateral cushion, whereas the anterior mitral leaflet is derived from the remnant of the superior and inferior cushions of the left side. At around 6 weeks of gestational age, there are thick fibromuscular strands which are attached from the trabecular LV myocardium to the end of the orifices of the left-sided AV valve. Now, these are the strands which will eventually give rise to the papillary muscle. Between 7 to 8 weeks, there is a process which is called as delamination, wherein there is separation of these muscular strands from the LV myocardium by this process of delamination, eventually resulting into two sets of muscles, and eventually which will give rise to your anterolateral and the posteromedial papillary muscles. Between 11 to 13 weeks of gestation age, there start appearing defects within the attachment of these muscular strands to the valve leaflets, and eventually a gradual process of lengthening and separation of the papillary muscle results in formation of the chordae tendinae. Now, any process which will not let this development happen will result in abnormal development of chordae tendinae and may eventually give rise to your arcade mitral valve, also called as a hammock mitral valve. And any process which halts the procedure of delamination of the muscular strands from the LV myocardium may result in the parachute mitral valve. Coming to mitral valve anomalies, so commonly we see the congenital mitral valve anomalies. Although they are isolated, very rarely, predominantly associated with other major congenital heart defects. The incidence is about 4 in 1,000 children with congenital heart defects, and as I said, predominantly 3/4 of the cases are associated with other major cardiac malformations. And again, within this subset, 55 to 75% of these mitral lesions are diffuse. By diffuse, I mean that more than one level of mitral valves components are affected. So you could have the annulus as well as the leaflets and the chordae all being affected. So congenital mitral stenosis, it's the most common form of mitral inlet obstruction, accounting for 0.2% of all the congenital heart defects. Again, isolation wise, this is rare, accounting for only 1 to 3%, predominantly associated with other left heart obstructive lesions, for example, the Schoen's complex. And congenital mitral stenosis is a group of variable combination of anomalies, which could include thickened leaflets with rolled margins. You could have a shortened and thickened chordae. You could have reduced intercaudal space or fibrous obliteration of these spaces. You could have abnormal caudal insertion into the papillary muscle. You could have reduced space between the two papillary muscles, or even papillary muscle hypoplasia. So congenital mitral stenosis, for ease of classification, is divided into two types, symmetric or asymmetric. And the predominant component for deciding whether it is symmetric or asymmetric is based on the caudal attachments. So of these two, the symmetric mitral stenosis is the most common, accounting for nearly half to three-fourths of the cases of congenital mitral stenosis. Here there is either a normal or symmetrical cord distribution between the two papillary muscles, although the papillary muscles could be small in size. Symmetric mitral stenosis is associated with variable degrees of annular hypoplasia, which also leads to restricted leaflet motion. The valve leaflet themselves could be thick and variably fused, as well as there could be commissural fusion. The papillary muscle distance could also be reduced, and along with reduced intercaudal space. The valve orifice is obviously less than the annular orifice. And the asymmetric variant of congenital mitral stenosis is where there is asymmetrical distribution of the cord and producing the types of parachute mitral valve. Another subset of mitral inflow obstruction could be because of commissural fusion, wherein the commissures are poorly defined and variably fused. But again, here as well, they are associated with poorly developed short chordae, and sometimes which may be completely absent. As a result, there is restricted leaflet motion and a markedly narrow central orifice. Another interesting variant of mitral inflow obstruction could be a double orifice mitral valve, which is a rare lesion seen in approximately 1% of autopsied heart with congenital heart defects. Just like other variants, this is also rare as an isolated anomaly, and it's commonly seen with other congenital heart defects, most common being the AV septal defect or the AV canal defect, or other left heart obstructive lesions and cyanotic heart diseases. There are usually three types of double orifice mitral valve which are described. So you could have a incomplete bridge type, wherein there is a thin fibrous strand of tissue connecting the free edges of the two leaflets and dividing the orifice into two separate orifices. You could have a complete bridge type, where there is a thick fibromuscular strand of tissue extending from the annulus to the leaflet tips and dividing the orifice into two separate orifices. The separate orifices usually have their own sets of chordae. And you could have an eccentric hole type of double orifice mitral valve, where usually there is a separate smaller hole within near the lateral commissure, and which again has its own set of chordae tendineae. Majority of the cases of double orifice mitral valve are associated with unequal orifices, and amongst them the most common is the variant where the posteromedial orifice is smaller in size. Very rarely, that is 15% of the cases, the orifices could be equal. Again, double orifice mitral valve presenting as mitral stenosis is uncommon, presenting in only 13% of cases. Majority would present with mitral regurgitation or a normally functioning mitral valve. Next among the subset is something called as mitral arcade or a hammock mitral valve, wherein there is direct connection of the papillary muscles to the mitral leaflets. It could be either a direct connection or through interposition of very, very short chordae. And as described during embryology, this is result of an arrest in the development stage of the mitral valve before attenuation and lengthening of the collagenized chordae tendineae. So here, as you can see, the picture on the left side is viewing from the left atrium, or what we describe as a surgeon's view, where you can see that the anterior and the posterior leaflet along with that small orifice and the papillary muscle below them with virtually absent chordae tendineae. And the figure on the right hand side, where it is being viewed from the left ventricular aspect, where you can the black arrow showing unusually short chordae tendineae and very thickened chordae tendineae. Coming to mitral ring, which is another rarely isolated anomaly, commonly seen associated with ventricular septal defects or other left-sided obstructive lesions. Amongst the mitral ring, there are two types described. One is a supramitral ring and another is a intramitral ring. Supramitral ring is located just above the mitral annulus and below the orifice of the left atrial appendage, as can be seen in this picture on the right hand side. It is the membrane is usually not adherent to the leaflets, and majority of the time the subvalvular apparatus, that is the chordae tendineae or the papillary muscles, are normal. The another subset, that is the intramitral ring, is where there is a fibrous membrane attached very closely to the leaflets and commonly associated with abnormal subvalvular apparatus. The supramitral ring has to be differentiated from core triatriatum sinister, which is basically a membrane within the left atrium but situated above the level of the left atrial appendage, and it is a result of failure of incorporation or adequate incorporation of the common pulmonary venous chamber into the left atrium. Last but not the least, the parachute mitral valve, which is seen in about 0.17% of community echo studies. Here again, there are two variants of parachute mitral valve which are described. So you have the true parachute mitral valve, wherein there is a single papillary muscle usually situated in the center, and all your chordae tendineae are connected to this single papillary muscle, as a result producing severe reduction in the intercaudal spaces and eventually mitral stenosis. You could have a parachute-like asymmetric mitral valve, wherein the chordae tendineae are attached predominantly to a single papillary muscle, which commonly happens to be the posteromedial papillary muscle, and the anterolateral papillary muscle is hypoplastic and abnormally located. It is located a little superiorly and very close to the leaflets. Again, parachute mitral valve is commonly seen with other obstructive lesions or conotruncal anomalies. So in this picture, you can see there is a predominant attachment of the chordae tendineae to the posteromedial papillary muscle. You can see the anterolateral papillary muscle, which is marked as ALPM, but which is displaced superiorly and located very close to the leaflets. So this was about the congenital etiologies for mitral stenosis. The other common etiology for mitral stenosis, what we see in our continent, is rheumatic mitral stenosis. So again, the mitral stenosis, that is the juvenile rheumatic mitral stenosis incidence, is gradually reducing. So classically described as mitral stenosis occurring before 12 years of age. It results from various etiologies which include fibrosis of the mitral ring, commissural adhesions, and fibrosis and contracture of the leaflets or the chordae and papillary muscles gradually over a period of time. The incidence of juvenile mitral stenosis ranges between 10 to 30% worldwide. Different studies from our subcontinent have shown incidence somewhere around 9.5 to as high as 13%. Coming to diagnosis of mitral stenosis, first and foremost, the chest X-ray. I'm not going to be talking about the clinical examination part here. We'll directly go on to the diagnostic test. First and foremost, the chest X-ray. So in milder mitral stenosis, and where there are no other significant associated cardiac anomalies, the chest X-ray either could be normal or there could be just a simple plain atrialization of left heart border or the straightening of the left heart border. In severe and extreme cases, there could be significant pulmonary venous congestion as seen in the X-ray on the right upper side. And because long-standing and severe mitral stenosis results in pulmonary hypertension, you could see a prominent pulmonary trunk in addition to dilatation of the right atrium. On barium study, you could see the indentation of the esophagus, which is produced by the dilated left atrium. Also, you could see a double contour on the antero-posterior chest X-ray produced by the dilated left atrium, and you could see the left bronchus which is being elevated above. So the carinal angle is wide because of the dilated left atrium. On ECG, you would expect signs of left atrial enlargement in the form of a biphasic P wave seen predominantly in the anterior chest leads, commonly in lead V1, in milder to moderate variants of mitral stenosis without much pulmonary hypertension. In severe and long-standing cases, you would expect signs of pulmonary hypertension in the form of right axis deviation, right ventricular hypertrophy, and even right atrial enlargement, as can be seen here in lead to prominent and tall P waves. Echocardiography, the most important tool for assessing the type of mitral stenosis, the severity of mitral stenosis, and even deciding on the treatment modality for the mitral stenosis. So 2D echocardiography can help you in deciding and evaluating the anomaly of the mitral valve. You could very well see a supramitral membrane or a hypoplastic mitral annulus or a parachute mitral valve arcade, absent or hypoplastic papillary muscles. Color flow mapping will help you in deciding the level of mitral stenosis and also for assessing if there is any associated mitral regurgitation. On quantitative Doppler, you can assess the severity of mitral stenosis. So usually either a pulse wave or a continuous wave Doppler assessment of the mitral inflow gradient can help you in assessing the severity. The mean gradient, which is assessed by tracing the mitral inflow Doppler signals, is the one which correlates with the cat-derived gradients. Now in this example, you can see a symmetric type of congenital mitral stenosis where the mitral annulus is small or hypoplastic, and as you can see on the color flow mapping, there is turbulence across this mitral valve. A double orifice mitral valve. So the best view to visualize this anomaly is either the parasternal short axis or from the subcostal view. So the left-sided frame showing two orifices of the mitral valve, the medial and the lateral. As you can see here, the medial orifice is a little larger than the lateral orifice. And on the right-hand side, you can see a three-dimensional demonstration of the double orifice mitral valve, and with both the components seen very well on 3D echo. Mitral arcade, another anomaly which can be easily picked up on echocardiographic study. So in this particular example, you can see that the unusually short chordae tendineae and the posterior mitral leaflet, as you can see, appears to be attached directly to the papillary muscle. Supramitral ring, again visualized very well on 2D echocardiography. So parasternal long axis view or the apical four chamber view are usually the best views for demonstrating the supramitral ring. Parachute mitral valve, another anomaly which can be easily picked up. So in this particular example, a parasternal short axis view demonstrating asymmetric type of parachute mitral valve where the leaflets appear to be, the chordae appear to be attached predominantly to the posteromedial papillary muscle. In addition, you can detect other cardiac anomalies. As seen in this example, there is associated VSD. Rheumatic mitral stenosis, again another interesting subset which has typical echocardiographic findings in the form of thick leaflets, doming anterior mitral leaflet, restricted, thickened and fixed posterior mitral leaflet, the anterior mitral leaflet giving the appearance of a hockey stick during opening, during diastole. The short axis view can help you in determining the mitral valve orifice area for determining the severity of mitral stenosis by planimetry. And in the last portion of this picture, what you can see is a three-dimensional demonstration of the orifice of the mitral valve, where there is extreme thickening of the mitral valve leaflets as well as the subvalve apparatus. And as you can see, there is fusion of both anterolateral as well as the posteromedial commissure. In addition, echocardiography for rheumatic mitral stenosis also is used to determine the severity of mitral stenosis by determining what is called as a Wilkins scoring system, wherein you look at 4 aspects of the mitral valve function, which includes mobility of the mitral valve, the severity of subvalvular thickening, severity of leaflet thickening, and presence of calcification. Based on this, you determine a score of the mitral valve stenosis, which could be as low as 4, and it could be as high as 16. So this helps in determining whether your balloon mitral valvuloplasty is going to be effective or not. So lower the score, better is the chances for having a good outcome after your balloon mitral valvuloplasty. Last but not the least, cardiac catheterization. Cardiac catheterization in today's era has a very limited role. It is predominantly used as part of intervention. It could also be used as a modality to assess operability prior to surgical intervention, especially in cases of long-standing mitral stenosis associated with other defects, like for example, a large ventricular septal defect, where you are not sure if the patient is operable or not. So you would do a cardiac catheterization to determine the pulmonary vascular resistance. So purely from the mitral stenosis point of view, you would need a left atrial pressure. If not possible, you could use a surrogate like a pulmonary capillary wedge pressure, and you would need a LV end diastolic pressure to determine what is the severity of mitral stenosis. Left atrial pressure, if possible, is the ideal pressure to obtain compared to pulmonary capillary wedge pressure. Pulmonary capillary wedge pressure, usually the difference between LV end diastolic and the pulmonary capillary wedge pressure usually tends to overestimate the severity of mitral stenosis, especially if you are using a balloon tipped catheter which is being placed quite proximally within the pulmonary artery and not deeply wedged within the pulmonary capillaries. In addition, a cardiac catheterization you could also use to assess the pulmonary arterial pressures, and as mentioned earlier, for determining the pulmonary vascular resistance. If there in long-standing mitral stenosis, you could have a gradient between the pulmonary artery diastolic pressure and your pulmonary capillary wedge or the left atrial mean pressure, which could mean that it is either as a result of pulmonary venoconstriction or pulmonary venous hypertension, or the patient has already developed pulmonary veno-occlusive disease, in which cases if the PVR is high, then obviously it precludes surgical correction. So to summarize, mitral valve is a complex of 4 components, which include the annulus, the leaflets, chordae, and the papillary muscle. Each component needs to be evaluated for abnormality because, as mentioned earlier, they are usually multi-level obstructions. Isolated congenital MS by itself is a rare anomaly. Look for other associated anomalies, especially other left heart obstructive lesions or a ventricular septal defect. Echocardiography by and large is usually quite adequate enough for diagnosing the type, severity of mitral stenosis, as well as for decision making in terms of surgical correction. So you could discuss your echocardiographic findings with the surgeon and make a decision as to what exactly should be the plan of action from the surgeon's point of view. So for example, you could have a parachute mitral valve where the surgeon knows that he needs to resect a wedge tissue from the papillary muscle so as to create adequate space of the secondary orifices of the mitral valve. Thank you so much. I hope this talk was useful for all of you, and I would be happy to answer any of your questions.